Hello, I'm Charmaine Hung.
And my name is Ashwin Subramani, and we're two of the internal medicine residents at the University of Iowa. And we're going to be presenting our QI project entitled Improving Advanced Care Planning Documentation in an Internal Medicine Resident VA Primary Care Clinic. So we've probably all encountered advanced care planning. Advanced care planning is very important to ensure that healthcare treatments are in line with patients' goals. It's also a good way of educating patients on the severity of their illness. It's very important that we have clear documentation of advanced care planning because oftentimes patients are in an acute situation and they might not be able to answer our questions, and we need to know what sort of treatments they would like in those situations. Some of the difficulties that arise with advanced care planning in the inpatient situation are, as I mentioned, in the acute situation, it might be impossible to actually talk to the patient. And also, it's never easy to have these conversations. And being a brand new provider to a patient can sometimes make it a little more difficult because there's not a well-established relationship between the provider and the patient. In a literature review that we conducted, we did find that having advanced care planning discussions in advance did reduce overall costs by thousands of dollars. That reduction in cost was primarily due to decreased utilization of inpatient hospital resources. We also did find a study that mentioned that advanced directives did not affect patient satisfactions or mortalities rates compared to patients who did not have these discussions prior to their hospitalization.
So for our project, we really sought to conduct advanced care planning discussions in the outpatient setting, as we felt that this was a non-threatening, non-acute setting, and the patient and provider already had an established relationship, knew each other, had some familiarity, and could really go into a deep discussion. So we utilized several tools that were already available in the VA system to help with this project. And we used the Life-Sustaining Treatment Note, or LST note, and the Care Assessment Needs Score, also called the CAN score. This is the Life-Sustaining Treatment Note. So basically it involves talking about what patients' goals are, if they want a full code or do not resuscitate. Also, what types of interventions they would be amenable to, like artificial nutrition. Also what's important to the patient in their life, like if they wanted to be able to attend a family gathering or if they really wanted to garden. Those are also things that could be documented. And the benefit of this note is that it's available in both the inpatient and the outpatient setting, and it's easily visible.
The CAN score is a score that's calculated by using 40 or so data points. And what the CAN score calculates is a score between 1 and 99. With 1 meaning the patient has approximately a 1% chance of 1-year mortality, and 99 meaning the patient has a predicted 99% chance of 1-year mortality. So by using these CAN scores, we're able to determine that patients with higher CAN scores have higher risk of 1-year mortality and are more likely to be hospitalized and are deemed our sicker patients.
So our target and SMART aim was to have patients with a CAN score above 85 really complete LST notes. So we wanted to increase the completion rate by 10% by the end of our intervention period, which ended on June 2020. So all of this took place in the Veterans Health Administration Patient Aligned Care Team Clinic. So there were 7 residents involved in our project, and each had a panel of their own primary care patients that they saw regularly. This ended up being about 500 patients total. Our stakeholders involved the patients, the providers, which were both residents and our mentors for our faculty, and then also palliative care providers who worked at the VA.
For our feasibility and impact matrix, we have this compilation of feasibility data and value data. We worked in the high feasibility and high value range, where we worked to complete LST notes in our patients with high CAN scores, because as I mentioned earlier, we thought patients with high CAN scores were the patients that were most necessary, most needing of LST notes, because they were at higher risk of 1-year mortality.
So this is our process map. So for every one of our patients, we would check the CAN score. If they scored above 85, then we would look and see if they had an LST note completed within the past year. If they didn't, we would assess if the patient was willing to talk about advanced care. If they were willing, then we would arrange and set up a discussion. We would have that discussion, and we would then document the contents of that meeting in the LST notes. We had a total of 99 patients among the resident panel who had a CAN score above 85. And out of those 99 patients, 8 patients already had an LST note completed. And notably, 7 of those notes were done while the patient was hospitalized and had to have a code status discussion. So 91 patients did not have a LST note. 2 patients actually died during the time period when we were conducting our project. So 89 patients were in the active intervention. And of those 89 patients, we were able to set up and complete goals of care discussions, advanced directives, and fill out the LST note. So overall, we started with 8% of the patients who had a CAN score above 85 having an LST note completed, and we were able to increase this number to 22% of patients with a CAN score above 85 having a completed LST note. And 1 patient did decline to complete an LST note after having a discussion about advanced directives. So in terms of successes, we felt that from the resident perspective, we were able to talk to our patients about something that we normally don't do. Normally, we're more focused on acute issues. We were able to hear more and learn more about these patients and what drives them in their life. So we felt that after learning more about our patients and having these discussions, we were better able to care for them and to pay attention to things that are important for them. And patients also appreciated the chance to talk about their health in a more long-term perspective. Some of the challenges, it was difficult to have some of these meetings. It took time to set up these meetings. These meetings also would be longer than a regular visit. So sometimes we would try to fit in these discussions into a regular clinic visit, during which time patients also had other issues they wanted to address that were acute and medical. So this was something that prevented us from having more notes completed.
With regards to future directions, one of the things that we kind of learned after we started our project was there is actually a growing VA initiative with regards to increasing the number of LST notes that completed with patients. So our project does kind of fall in line with that initiative, which is good, and it gives us a lot of different avenues to grow and expand our project. For one, we think it'd be a good idea to expand into further resident and provider clinics. It worked well in our resident clinic, and we think going to other clinics would be a great idea. We also did talk with palliative care, and they seemed open to the idea of us possibly opening up discussions with our patients about sending patients to palliative care so that further discussions about goals of care and future treatment options could be had in a palliative care environment. In times of COVID-19, we found that it is especially important to have advanced care discussions with more instances of patients getting sick. It's important to have a good understanding and good documentation of patients' wishes with regards to treatment. And we also have been able to use our CAN scores to kind of stratify our sick patients, which has been particularly helpful in these times of COVID-19 as well. We would like to thank Dr. Broderick, who's a palliative care physician here at the Iowa City VA, who was very helpful in our coordination and organization of this project. And we'd also like to thank our faculty members, Dr. Iverson and Dr. Johnson. And we'd like to thank all of our white team VA patients who took the time to kind of have these conversations with us and help us develop relationships with them. These are some of our references, and thank you for taking the time to listen to our presentation.
Thank you very much.